Okay, which I already told you a piece of information. The ability to stimulate beta adrenergic receptors depends on the substituent near the nitrogen atom. No, this means that radical after the amino group. The bigger is this radical, this substitute, the stronger the drug stimulates beta receptors and weaker stimulates alpha adrenal receptors. So I told you that already. That's why adrenaline equally stimulates alpha and beta adrenergic receptors because it has the radical, but it is small, only methyl, yes. Noradrenaline doesn't have radical, so it only stimulates alpha adrenergic receptors, and isodrine, which is isoprenaline, only stimulates beta because this radical in amino group is quite big, yes. This is isopropyl propyl radical. Okay, and now what actually happens when we stimulate this receptor? What happens is activation of the enzyme adenylate cyclase if we stimulate beta-1 receptors. This adenylate cyclase is the primary mediator. Then primary transmitter, okay? And then adenylate cyclase stimulates the synthesis of CMP. CMP, this is cyclic adenosine monophosphate, cyclic. From ATP, you know what this is, and this cyclic adenosine monophosphate activates the enzyme proteinase, which then leads to activation of metabolic enzymes. The metabolic effect depends on which organ in which the effect takes place. So different metabolism changes can be, for example, as we discussed, in the liver. In the liver, it will be increased glycogenolysis. In the adipose side, it will be increased lipolysis, yes. In the juxtaglomerular cells, it will be increased renin production. So different metabolic effects depending on the cell on which we affect. Okay, this all was about the natural norepinephrine, epinephrine, the stimulants of adrenergic receptors. And now we're going to not natural, but synthetic, the drugs, yes. Adrenomimetics. They are adrenergic agonists, so they stimulate. It's a group of biologically active substances of natural and synthetic origin, stimulating adrenergic receptors in the body and causing various metabolic and functional changes in the body. So the most important word here is that they are stimulating adrenergic receptors. Yes, my heart for this word. Okay. Oh, sorry. Hearts. So let's now see how these stimulants are classified. Firstly, we already know that epinephrine and adrenaline, epinephrine, which is adrenaline, can stimulate both alpha and beta adrenal receptors. But also we have more selective drugs. For example, stimulating only alpha adrenal receptors. They are norepinephrine, phenylephrine, midodrine. Also we have drugs of alpha-1, yes? Also we have drugs affecting only alpha-2 adrenal receptors, alpha-2 adrenomimetics. For local action, naltrexone, xylomethylene, oxymethylene. Why for local action, I will tell you, is because they are nasal, they are used as nasal drops. Nasal drops for if you have the stiff nose or running nose, yes, to stop this in case of cold. And for the resorptive action, we have clonidine drugs and guanfacine drug, and they affect on CNS. They affect strongly on CNS. Okay. Also, we have selective adrenomimetics, which affect on beta receptors. And beta adrenomimetics, they can be classified as non-selective and selective. Non-selective, they stimulate all types of beta receptors, beta 1 and beta 2 receptors. They are orthoprenolin and isoprenolin. But also we have drugs which stimulate only one type of receptor, beta 1 or beta 2 receptor. And beta 1, it will be stimulating dobutamine drug, and the stimulants for beta 2 receptors, for example, salbutamol, phenysterol. This drug affects mostly on the heart, and this affects mostly on the bronchi. Remember about the beta 2 receptors? I told you that beta 2 is for relaxing. Beta 2 is the relaxing receptors. So these drugs, they will relax the bronchial muscles. Also, we have drugs which are indirect adrenomimetics, sympathomimetics. What does it mean? They are indirect, so they don't affect directly receptors. They work through the accumulation of the natural norepinephrine. So they work through the activation, accumulation of the natural norepinephrine. What does it mean? In this case, norepinephrine will be synthesized in the vesicule, and with the help of this drug, the bigger amount of norepinephrine, will be accumulated in the synaptic cleft, and it will work better, stimulate the receptors better. So ephedrine, it's the sympathomimetic drug. It doesn't affect directly on the receptors. It just helps our natural norepinephrine to affect more. Понятно? So this is the difference. These stimulate directly receptors, and these don't stimulate receptors. They only help norepinephrine to accumulate more. And so here are the tables with the explanation of when we should administer these drugs, which adverse effects can be. I'm not going to read these tables. You can make a screenshot and read them because actually I think everything is clear here, because I already told you that receptors can be stimulated, and then it depends on where are these receptors stimulated. If we are talking about bronchoconstriction, so it will be relief of bronchospasm. If we are talking about vessels, it will be the contraction of blood vessels, increased blood pressure, so it may be used in the anaphylactic shock, and so on. But of course, it can cause some side effects, some adverse effects, which are cardiac arrhythmia. Also, it can be the presocardiac reflex, which can decrease the heart rate, and so on. So many different side effects. So please make the screenshot of them if you need it. Oh, sorry, that one. So here you can make a screenshot if you need it. Next, the same about alpha-1 receptor agonists, alpha-2 receptor agonists, which can be used for the relief of collapse, for the treatment of rhinitis, as I told you, nasal drops. This, yes. Drugs affecting directly on CNS will inhibit the vasomotor center, by the way, as you remember, and which will be used in the treatment of hypertensive disease. Here also you can make a screenshot. Now, beta receptors and beta agonists. So we have already discussed that beta 1 is mostly located in the cardiac cells, in the heart. Yes, and also bronchoconstriction here can be the indication for these drugs. Bronchi, they have beta-2 predominantly, don't forget. Then sympathetics, which doesn't affect the receptors directly, but helps to accumulate norepinephrine. Well, now, once again, let's see how it works. It stimulates the release of norepinephrine from vesicles to the synaptic gate. Then it blocks the enzyme catechol orthomethyltransferase and monoamino oxidase because they will not be able to destroy this norepinephrine, because when it goes outside the cell there is a risk that it will be destroyed, but we don't want that. We want to accumulate them. That's why we should block the enzymes and stop them, prevent the destruction of our norepinephrine. So it helps us to accumulate this norepinephrine in the synaptic gate, and finally it will stimulate the CNS, stimulate the constriction of the blood vessels, and so on. I mean, what so on? Stimulate the heart activity and dilate the bronchi. And this all was about the drugs which stimulate adrenal receptors, but everybody understands that there are also drugs which block adrenal receptors. So they are called adrenal blockers. They are antagonists to these receptors. We have many situations in which we don't want to stimulate the sympathetic nervous system, and we want to block it, actually, to stop it, to stop the action of it. To tell you the truth in this situation, living in today's world full of stress, full of difficulties, actually makes our sympathetic system always work. So we are always on stress. Stressed out, I don't know. We always have high blood pressure, we always have to work a lot, and our heart is working too much, and that's why actually our problem is overactivity of the sympathetic system. That's why in this case using of drugs which block the effects of sympathetic system becomes more and more relevant. So that's why we use adrenal blockers quite often. Okay, what can be the adrenal blockers? As we have already discussed in the drugs which can stimulate the adrenal receptors, we have some selective drugs and non-selective. Non-selective, which don't select actually the receptors on which they will work. They affect both 1 and 2, alpha 1 and alpha 2, yes, if we are talking about alpha adrenal blockers. And the examples are here: phenethylamine, nitsergalin, tropophen. Also, we have alpha 1, more selective adrenal blockers. Alpha 1, they are prazosin, doxazine, terazosin, tamsulosin. They are used in the urological practice in adenoma of prostate gland. And we also have alpha 2 adrenal blockers, for example, yohimbine, which is not actually used in today's practice. Now we are talking about beta adrenal blockers, which can be also selective. This selective, yes, beta 1 only, and non-selective, which block both beta 1 and beta 2. For non-selective, these examples we have. For selective, these examples. And what you can see, that all the drugs which are beta blockers, they end with lol. Лол, пиндолол, тут тоже лол должен быть, лол, лол, and everywhere the same ending, lol. So beta blockers always end with lol, okay? It will be easier to remember if you remember that they are lols. Then, oh, sorry again, beta adrenal. And also we have some drugs which are paradoxically both alpha and beta adrenal blockers, which are labetalol, carvedilol, prodoxolol. Here you should make a difference, not confusing them with just beta blockers, because they are also ending with lol. But for your not being very stressed with that, they are only three names here, so it is possible actually to remember them. Okay, Now let's see how the adrenal blockers actually affect, for example, on the heart, because for us, the mostly widespread disease connected with adrenaline is the heart disease, any type of heart disease, arrhythmia, insufficiency of the how do we call it, like heart failure, yes, ischemia, myocardial infarction, and so on. So all this is connected with the effects of adrenergic drugs. And let's see what happens if we block alpha-1 adrenoreceptors. Давайте посмотрим. By blocking of alpha-1 adrenoreceptors, we have the peripheral vasodilating action. Why? Because alpha receptors are stimulating the contraction of vessels. If you block them, there will be no contraction, so they will dilate. So it will be vasodilating action, which leads to improved perfusion and metabolism of skeletal muscles, decreased hemodynamic load of the heart. This leads to increased left ventricular ejection fraction, and the improved perfusion and metabolism of skeletal muscles leads to decreased cytokine synthesis. Decreased cytokine synthesis, what does it mean? Cytokines, they like bradykinin, interleukin, then maybe serotonin. They are synthesized when in the skeletal muscle there is any problem, and it has, for example, not enough oxygen and it wants more blood supply. So if we have the vasodilating effect, so there is enough blood supply, and our muscles, they don't make cytokines, they don't call more blood. Okay. This all leads to the suppression of myocardial hypertrophy and anti-remodeling effect. Why this is very important? Because anti-remodeling effect, like it makes your heart stay normal, because remodeling is the connective tissue forming in the heart. So we, of course, we don't want that, because the function will be reduced if we have some connective tissue in the heart. And also these drugs have significant antioxidant activity, which suppresses the oxidative stress of the cells, and this all suppresses the myocardial and skeletal muscles apoptosis. So the cells, they will not die. So we can see by this scheme that alpha adrenoblocking, it's not just relieving the high blood pressure, it is also the protection of your heart not to destroy the cells. What is interesting here about the blood pressure? Давайте подумаем. Let's firstly remember, I will show you a thing. We will firstly remember that in the blood vessel, let it be the blood vessel, this drawing, not a drawing class, but I will make a blood vessel for you. Okay, this is blood vessel. And we remember what kind of receptors do we have in blood vessels. In blood vessels, we have predominantly alpha-1 adrenoreceptors, alpha-1 adrenoreceptors, and also we have beta-2 adrenoreceptors. Alpha-1 and beta-2 adrenoreceptors. So what's going on? If we are giving adrenaline to this blood vessel, adrenaline, I will show you. If I'm giving adrenaline, it stimulates firstly this alpha-1 adrenoreceptors, and the function of alpha-1 adrenoreceptors is to contract the vessels. So after giving our patient with adrenaline, we will have contraction of vessels and the blood pressure will increase. Yes? Then after some time it will again decrease back and we are given the phentolamine. Phentolamine, what is it? Phentolamine is the selective alpha non-selective alpha adrenal blocker. So it blocks alpha adrenal receptors. Okay, it blocks, so the contraction will be less. That's why we can see here the decrease of blood pressure. Yes, it decreases because already no contraction can be, even with the natural adrenaline, contraction will not happen. And then we are given again back adrenaline. But what happens? Adrenaline now cannot work on these receptors because they are blocked. But it can work on beta-2 receptors because we remember that adrenaline works both alpha and beta adrenal receptors. Да? So we remember that adrenaline works on both types of receptors. So if one is blocked and this action cannot be made, but second still works, and actually it was working in the first case also when in the beginning when we gave, it was also working, but it was not that visible because the effect from alpha was much stronger. But now we don't have effect from alpha because this is blocked, and we have only effect on beta-2, and we remember that beta-2 is always relaxation, and that's why after injecting adrenaline we have even more reduction of blood pressure because now it works only for relaxation. Is that clear? I hope yes. Okay, and now talking about beta adrenal receptors blocking, how that can work in our body. Firstly, we discussed that we have several places where beta receptors can work. For example, in the kidneys, in juxtaglomerular apparatus, as you remember, it can reduce the renin secretion, which is showed here. The renin secretion will be reduced. That's why renin, angiotensin, aldosterone system will also be reduced, which stops the norepinephrine secretion. Not stops, but doesn't help. Yes, and this all leads to decreasing the progression of the chronic heart failure. This decreases the beta-1 receptors in the myocardium. This helps to increase the myocardium contractility because when we have more beta-1 receptors, they are less sensitive. And when we have less of them, they are more sensitive. Direct effect on myocardium of beta adrenal receptors in myocardium will reduce the heart rate and reduce the risks of arrhythmia. And it will also recover the energy potential of the cell and reduce the ischemia. Finally, we have the preventing of the necrosis of the myocardium by the help of all these different methods. So what we can say about this? All the drugs which we study in alpha and beta adrenal blocking block, they are not only helping to reduce the blood pressure, they are also helping to prevent the destruction of the cells of the heart. So they are like security in our heart, because the heart can be affected by many different systems, and if you help it to relax sometimes, not relax very much, but a little bit, it helps the heart to work better afterwards. Okay, this was everything, I guess, that I wanted to show you. Yes, спасибо за внимание. Please enjoy studying pharmacology with me. Thank you very much. We should stop our recording. How to do that?